Tuberculosis, TB, abdomen. Introduction. Tuberculosis, TB, is a life-threatening disease which can virtually affect any organ system. India has the world's largest tuberculosis cases, which is around 26% of the world TB cases, followed by China and South Africa. There were an estimated 0.45 million new cases of multi-drug resistant TB worldwide in 2012. The prevalence of TB has increased in both immunocompetent and immunocompromised, and it can affect virtually any organ. The primary site of TB is usually lung, from which it can get disseminated into other parts of the body. Definition. Abdominal tuberculosis, TB, is a type of TB that affects the gut, the peritoneum, the lining of the abdominal cavity, abdominal lymph nodes, and, more rarely, the solid organs in the abdomen, liver, pancreas, and spleen. Abdominal TB leads to severe illness in adults and children, and can cause complications, such as bowel rupture, which can lead to death. TB of the gastrointestinal tract, digestive system, and abdominal cavity is known as abdominal tuberculosis. Etiology. Causes. Mycobacterium tuberculosis. Modes of involvement in abdominal tuberculosis. By ingestion. Infected food or milk, primary intestinal tuberculosis. Infected sputum, secondary intestinal tuberculosis. Hematogenous spread from distant tubercular focus. Contagious spread from infected adjacent foci. Through lymphatic channel. Pathophysiology of abdominal TB. There are several ways by which tuberculosis can involve abdomen. The first pathway is ingestion of infected material. Firstly, the tubercle bacilli may enter the intestinal tract through the ingestion of infected milk or sputum. The mucosal layer of the GI tract can be infected with the bacilli, with formation of epithelioid tubercles in the lymphoid tissue of the submucosa. After 2 to 4 WK, caseous necrosis of the tubercles leads to ulceration of the overlying mucosa, which can later spread into the deeper layers and into the adjacent lymph nodes and into peritoneum. Rarely, these bacilli can enter into the portal circulation or into hepatic artery to involve solid organs like liver, pancreas, and spleen. The second pathway is hematogenous spread from tubercular focus from elsewhere in the body to abdominal solid organs, kidneys, lymph nodes, and peritoneum. The third pathway includes direct spread to the peritoneum from infected adjacent foci, including the fallopian tubes or adnexa, or So's abscess, secondary to tuberculous spondylitis. Lastly, it can spread through lymphatic channels from infected nodes. Signs and symptoms. Clinical feature of abdominal tuberculosis is varied. The most common symptoms are pain in the abdomen, loss of weight, anorexia, recurrent diarrhea, low-grade fever, cough, distension of abdomen, a lump, fluid in the abdomen or a doughy feel of the abdomen, enlarged lymph glands. Classification of abdominal tuberculosis. The abdominal TB usually occurs in 4 forms. 1. Tubercular lymphadenopathy. 2. Peritoneal tuberculosis. Wet ascitic type. Fixed fibrotic type. Dry plastic type. Encysted loculated type. 3. Visceral tuberculosis. Liver, pancreas, spleen, etc. 4. Gastrointestinal tuberculosis. Esophageal tuberculosis. Gastric tuberculosis. Duodenal tuberculosis. Jejunal and ileocecal tuberculosis. Colorectal tuberculosis. Tubercular lymphadenopathy. Abdominal lymphadenopathy is the most common manifestation of the abdominal TB. It usually follows the drainage of the affected organs, though it can affect any lymph node in abdomen. The most commonly involved lymph nodes are the mesenteric nodes, omental nodes, those at porta hepatis, along the celiac axis and in peripancreatic location. The commonest route of transmission is usually secondary to ingestion of the infected material along with associated intestinal TB. Hematogenous route of transmission and contiguous spread from adjacent affected abdominal organ can also occur. The most common presentation is presence of multiple mildly enlarged nodes in clusters which are circular or ovoid. They usually have central areas of caseous necrosis with peripheral enhancement. Peritoneal tuberculosis. Traditionally, the peritoneal TB is divided into three types. The wet acidic type is more common and is associated with large amounts of free or loculated fluid in abdomen. The ascites is usually of high density due to increased protein content of the inflammatory exudate. Associated peritoneal enhancement is usually present. The fixed fibrotic type is relatively less common and is characterized by involvement of omentum and mesentery and is characterized by presence of matted bowel loops on imaging. Loculated ascites can be occasionally present, and the dry plastic type is characterized by fibrous peritoneal reaction, peritoneal nodules and presence of adhesions. However, this classification is usually not adequate and a combination of features are usually noted. Visceral tuberculosis. Isolated involvement of abdominal solid organs is relatively uncommon and occurs in 15% to 20% of all patients with abdominal TB. The genitourinary system is the most commonly involved, followed by liver, spleen and pancreas. The mode of spread is through hematogenous route. Only 15% of patients have concomitant pulmonary TB. Moreover, these patients present with non-specific symptoms, all of which leads to difficulty in making prospective diagnosis. Cross-sectional imaging with USG, multi-detector CT, and MRI plays an important role in the diagnosis and post-treatment follow-up of tuberculosis. Gastrointestinal tuberculosis. The most common site of the gastrointestinal TB is ileocecal location, followed by jejunum and colon. The esophagus, stomach and duodenum are rarely involved. Esophageal TB. The esophageal involvement is extremely rare in immunocompetent patients and account for only 0.2% to 1% of gastrointestinal, but it is more commonly seen in AIDS patients. The symptoms are usually retrosternal pain, dysphagia and odynophagia. In esophagus, TB usually occurs in the middle third and manifests as ulcerative lesion or a tumor-like lesion. On barium studies, extrinsic TB is seen as narrowing or displacement of esophagus. In late stages, the patients may present with formation of ulcers, strictures and fistulae. In fibrotic mediastinal disease, traction diverticulae can occur in the adjoining esophagus. The diagnosis of primary esophageal TB is usually made on histopathological examination. Since the tuberculous granulomas are located deep in the submucosal layer of esophagus, multiple and deep esophageal endoscopic biopsies should be obtained for optimum diagnosis. Gastric TB. The gastric involvement is usually associated with pulmonary tuberculosis or immunodeficient state. Primary involvement of the stomach is rare, 0.4% to 2%, because of the bactericidal property of the gastric acid, scarcity of lymphoid tissue in gastric wall and thick intact gastric mucosa. The other routes of spread can be either hematogenous or from adjacent lymph nodes. The patients may present with non-specific symptoms of vague epigastric discomfort, weight loss and fever, or may present with features of gastric outlet obstruction. On imaging, these lesions can appear as benign ulcers or erosions. In late stages, features of pyloric stenosis with distorted antropyloric region can be present. Endoscopic images. Gastric tuberculosis with gastric outlet obstruction, before, A, and after, B, balloon dilatation. Duodenal TB. Duodenal involvement is seen in 2% to 2.5% of all gastrointestinal TB cases. The most common site of primary involvement is the third part of duodenum. It is usually complicated by formation of strictures or fistulas. These patients usually present late with features of obstruction where strictures are identified on imaging or an extrinsic impression by lymphadenopathy is noted. Barium studies demonstrate presence of narrowing either extrinsic or intrinsic. Formation of fistulas communication is readily identified by real-time barium studies. Cross-sectional imaging like CT demonstrates luminal narrowing, mural thickening of duodenum and also adjacent lymph nodal masses causing compression. Jejunal and ileocecal TB. The most common site of GI involvement is the ileocecal region, which is involved in 64% of cases of gastrointestinal TB. The terminal ileum is more commonly involved because of the various contributing factors like stenosis, presence of abundant lymphoid tissue, increased rate of absorption at this site, and closer contact of the bacilli with the mucosa. The clinical features of small intestinal TB are protein, and the patients usually present with colicky abdominal pain, borborygmy, a rumbling or gurgling noise made by the movement of fluid and gas in the intestines, and vomiting. Figure 12 endoscopic images. A. Ulcerative form of ileocecal, IC, tuberculosis, multiple ulceration on IC valve, cecum and ascending colon with nodularity in intervening area and some mucosal bridges. B. Hypertrophic form of ileocecal tuberculosis, mass-like lesion on IC valve with ulceration on surface. C. Ileocecal tuberculosis, contracted cecum, narrowed and deformed IC valve and multiple ulceration on IC valve, cecum and ascending colon. D. Superficial ulcers in terminal ileum. E. Gaping IC valve with multiple ulcers on IC valve, cecum and ascending colon. F. Terminal ileal stricture with multiple ulcers on ileocecal valve and contracted cecum. Plain X-ray abdomen may show enteroliths, features of obstruction like dilated bowel loops with multiple air fluid levels, or presence of air under diaphragm in case of perforation. In addition, there may be calcified lymph nodes, calcified granulomas and hepatosplenomegaly. Colorectal TB, isolated involvement of colon is 10.8%. The incidence is increased in the immunocompromised patients and patients with AIDS. The cecum is the most common site of involvement of colon, but it is usually involved in contiguous involvement with the terminal ileum and IC junction. The most common clinical features are abdominal pain followed by loss of weight and appetite and altered bowel habits. During colonoscopy, the most common finding of colorectal TB is presence of ulcers, which are linear fissured, transverse or circumferential and are covered with dull white or yellow exudates. Diagnosis of abdominal TB. Assessment begins with history taking and physical examination. Although diagnosis can be confirmed by isolating the TB germ from the digestive system by either a biopsy or endoscopy. However, other supportive tests that may be done are the Mantoux test, chest X-ray, abdominal X-rays, with or without barium, and scans such as ultrasound and CT scan. Although neither clinical signs, laboratory, endoscopic findings and radiological signs nor the bacteriological and histopathological findings are gold standard for the diagnosis of abdominal TB, the diagnosis of abdominal TB is usually made by adequate radiological and histopathological studies. The methods of biopsy include endoscopic GI mucosal biopsy, image-guided percutaneous biopsy, endoscopic ultrasound-guided biopsy, and surgical, open or laparoscopic, biopsy. The caseation necrosis in granulomas is the histologic hallmark of TB. In intestinal tuberculosis, the granulomas are multiple, larger, more than 200 micrometers, and coalescent in mucosa and submucosa. Hematologic findings are non-specific and include raised erythrocyte sedimentation rate, anemia and hypoalbuminemia. The tubercular acidic fluid has protein more than 3 GDL, with a total cell count of 150-4000 μl and consists predominantly of lymphocytes. The acidic fluid to blood glucose ratio is less than 0.96 and serum acidic albumin gradient is less than 1.1 GDL. The yield of organisms on smear and culture is low. Staining for acid-fast bacilli is positive in less than 3% of cases and a positive culture is seen in only 20% of cases. Acidic fluid adenosine deaminase, ADA, levels are elevated in tubercular ascites. Serum ADA level above 54 UL, acidic fluid ADA level above 36 UL and an acidic fluid to serum ADA ratio more than 0.98 are suggestive of tuberculosis. However, in cases of co-infection with HIV, acidic ADA levels can be normal or low. Also, falsely high values can be seen in malignant ascites. Interferon gamma levels are also elevated in tubercular ascites. The sensitivity and specificity increased by combining acidic fluid other and interferon gamma assay. The various radiological studies are used for the diagnosis of abdominal TB include ultrasonography, USG, CT, barium studies and magnetic resonance imaging, MRI. Ultrasound is an initial modality of choice which is useful in picking up lymphadenopathy, tubercular ascites, peritoneal thickening, omental thickening and bowel wall thickening in some cases. Plain radiographs may show enteroliths, perforation and features of intestinal obstruction. Barium studies are still gold standard in diagnosing strictures, fistulae, erosions, etc. Contrast-enhanced CT and CT enterography provide adequate cross-sectional imaging in depicting various forms of abdominal TB. In the recent years, various molecular and immunological techniques are used as a new approach for the rapid diagnosis of abdominal. The clinical samples can be acidic fluid, lymph node, thickened omentum or mesentery. The insertion sequence IS6110 is used as a target for polymerase chain reaction, PCR, amplification in these samples. Real-time assay using fluorescence resonance energy transfer hybridization probes show a positivity index of 36% in those patients with clinical and radiological suspicion of TB, but with negative acid-fast bacilli, AFB, and culture. In addition, immune characterization show depleted CD4+ count and increased levels of interferon gamma and tumor necrosis factor alpha cytokines. Multiplex PCR using MPB64 and IS6110 are useful in rapid diagnosis of gastrointestinal TB. Multiplex PCR has sensitivity and specificity of 90% and 100%, respectively in confirmed AFB culture histopathology cases of gastrointestinal TB and positive results in 72.41% of the suspected gastrointestinal TB cases. Management of abdominal TB. Medical management. Abdominal TB is generally responsive to medical treatment alone, so early diagnosis can prevent unnecessary surgical intervention. In general, with advent of anti-tuberculous therapy, surgery is usually reserved for those cases where it is absolutely indicated, as in cases of non-resolving intestinal obstruction, perforation and abscess or fistula formation. A 6-month treatment regimen is recommended as per the revised National Tuberculosis Program guidelines. Many clinicians extend the treatment regimen to 9 or 12 months. The commonly used drugs during the initial 2 months therapy, intensification phase, are isoniazid, INH, rifampicin, ethambutol and pyrazinamide thrice weekly. During the next 7 to 10 months, continuation phase, the drugs commonly used are INH and rifampicin. Surgical management. The first type is the surgery which is done to bypass the involved segments of bowel, as in case of an enteroenterostomy or an ilotransverse colostomy. These surgeries are usually complicated by blind loop syndrome, fistula formation and recurrent disease in the remaining segments, and hence usually not performed routinely. The second type of surgeries are those involving the radical resection like a right hemicolectomy, which are feasible with the advent of effective anti-tuberculous drugs so as to eradicate the disease completely. These kinds of conservative surgeries are usually preferred nowadays. The tuberculous bowel perforations are usually treated with resection of involved segments with primary anastomosis. Nursing management. Nursing diagnosis. Acute pain related to damage of mucosa layer of stomach. Hyperthermia related infectious process. Fluid volume deficit related to vomiting. Imbalanced nutrition less than body requirement related to disease process. Sleeping pattern disturbance related to pain. Anxiety related to hospitalization. Knowledge deficit related to treatment process. Complications. Untreated TB of the intestine may lead to intestinal obstruction, fistula or even abscess and perforation with resultant peritonitis. Prevention of TB abdomen. Take all of medicines as they are prescribed, until the doctor takes of them. Keep all doctor appointments. Always cover mouth with a tissue when cough or sneeze. Seal the tissue in a plastic bag, then throw it away. Wash hands after coughing or sneezing. Don't visit other people and don't invite them to visit. Stay home from work, school, or other public places. Use a fan or open windows to move around fresh air. Don't use public transportation.
So guys, thanks for watching my video. You can like and comment on my video, but don't forget to subscribe my YouTube channel to watch quality content like this. Thank you guys.